everyone. Welcome to session 5A, which is our session on Stride. We have three presentations, but two speakers. Why don't we have two slides? First is for Dr. Sean Marshall, who is a specialist in physical medicine and rehabilitation and full professor and division head of physical medicine and rehabilitation at the University of Ottawa, Canada, and the Ottawa Hospital. He is also department head of physical medicine and rehabilitation. His clinical practice focuses on acquired brain injury rehabilitation. He has a Master's of Science degree in epidemiology and community health and is active in research involving brain injury rehabilitation, as well as driving and disability. He is the principal investigator for the Canadian Institutes of Health Research team for older driver research, where he leads the Candrive prospective older driver study, which aims to develop an older driver risk stratification tool. Dr. Marshall.
Great, thanks. Well, I'm very pleased to be able to present our Candrive team research and give you an update on how this prospective study has progressed. I'm going to do two talks, one about the development of the tool and two, some preliminary validation of the tool and how it's going. And of course, I'd like to recognize all the researchers involved in the Candrive project and all our stakeholders. So I'm going to give some background first on what's happening. Or what's happened. So again, this started, probably, approaching about a decade ago. Common cohort inclusion criteria, age 70 and older. So we're looking at older drivers, life expectancy more than 5 years at a time. General license had to be held, and they had to have access to and drive a vehicle at least 4 times a week. So these are high volume drivers. They needed to consent to release their personal driving records and information, and they had to be under the care of a family care provider at the time. We did start with Common Cohort. It was a Canadian-based study, 7 Canadian sites, 4 provinces. We recruited 928 older drivers, and we went on to have the Candrive site join us a year later, including Melbourne, Australia, and Wellington, New Zealand, where we recruited an extra over 300 older drivers. They were age 75 and older. It was a pretty complex, comprehensive study. Physical and sensory and cognitive assessments, driving habits and behavior questionnaires were done annually, followed by every 4 and 8 months. We did a review of their driving record, so an interview, took their self-reported crashes, reviewed their overall health status, and so significant changes in their health, and self-reported collisions were collected. We also collected their driving data. We had in-car recording devices. On all these cars, they're all instrumented. In the end, we had over 40 million kilometers driving down to the second. We had like 120 per second for 40 million drivers. Demographics, just to show you who we collected with the Candrive sample. Obviously, we had some attrition as the study progressed. Male-female ratio about 70-30, which is fairly representative of the Canadian population. And the ages when we started to recruit them, of course, at the end of the study, 7 years later, they're all 7 years older. But the average age is about 75 to 76 in the Canadian sample. Interestingly, we did compare them to the Canadian Community Health sample. This was useful because we wanted to know who did we recruit. And other than rural-urban, we are pretty representative of the older driver population. Older drivers tend to be more affluent, tend to be better educated, tend to be healthier than the general population. That's kind of what when we compared to the Canadian Community Health sample, we actually published papers suggesting they were. This is just showing the approximately 40 kilometers worth of data that we have on the drivers and where they drove. Not surprising, many in Basin, Ontario, and that's where the heat map is. You can even see they're down to Arizona and to Florida, depending if they're east or west, where they tended to vacation. Self-reported driving exposure. We have calculated driving exposure because we have their GPS data and their in-car recording devices. But self-reported data shows that they were still actively driving, some well over 20,000 kilometers per year. And we also had the lower driving population. This is relevant to our analyses. Collision results, and I'm going to talk about this in a minute when we look at our derived tool. We had over, these were police-reported at-fault collisions. So this is our outcome. We felt that this was a meaningful outcome versus, for instance, fender benders and other things. We were looking at this because it was significant enough to have damage or injury. These were the ones that were reported to us, 48% at-fault rate. This is independently determined, which I'll show you in a minute. So really, where do we want to go? Well, we had the study. It was a comprehensive study looking at many things. My collaborator, colleague, Dr. Malcolm Hing, and I were primarily interested in a risk stratification tool to help physicians, identify who may be at higher risk. We went in initially when the study started off, and research changes. We were looking at a clinical decision rule. Really, that would be a yes, no. You're fit, you're not fit. We actually changed course in that when statistics were becoming more available through research through Ottawa, the Ottawa Hospital Research Institute, Ian Steele and his emergency research group, to a risk stratification tool. The difference being, and I'll demonstrate to you in a few minutes, saying this is your risk category. It doesn't say you're going to have a crash or not have a crash. And similar to someone, what's your risk of having a heart attack? Doesn't mean you're going to have a heart attack. I mean, what's your likelihood compared to the general population? And we felt that this might be a better strategy to go. So we looked at, there's different tools we could develop. This one's going to focus on the healthcare practitioner tool. There could be self-administered tools that people could do online, but we thought we'd go with this one. We wanted to look for an objective tool to find the best combination of predictive variables and the primary outcome was at-fault collisions adjusted per kilometer driven. We went for adjusting per kilometer driven for the mere reason that the safest driver is the driver who never drives the car. If you drive 0 kilometers per year, you're not likely to have a collision. So we did primary at-fault collision. We had de-identified licensing body accident reports. We had all the primary reports from the Ministry of Transport. And we had 2 external at-fault assessors who were independently assessing whether the driver was at fault based on the police record. And then the reviewers assigned at-fault status, and assessors discussed the results and resolved discrepancies prior to sending back to us, Candrive. So it was done externally to our group. And then for the analysis, what we did was we had to screen a number of different potential variables. This is a large study where I had over 1,400 variables in total, and not all of these relate to driving. The make and vehicle of your car probably isn't any predictive of driving ability. Your other personal characteristics may not also contribute, yet we'd have that information as part of the study. So we screened, we did univariate data analyses, and then multivariate data analyses. We came down to 9 variables that would be potentially included in our model, and ultimately 4, which is where our Candrive risk stratification tool came off. I'm going to show you here the data for this, and we're looking at domains. So often in older driver literature, you're looking for often dementia, or these are sort of things. But these are healthy older drivers. So dementia, we can agree that if you're markedly demented, probably shouldn't be driving a motor vehicle. If you're markedly impaired, you may not be able to drive a vehicle. Our tool is looking at kind of different domains. We're looking at psychosocial factors, cognitive, physical, overall health status, and behavioral factors as things to consider. Our tool in the end ended up being these four categories, and they were cognitive tests. So road sign recognition test was a deductive reasoning task, probably testing executive function. The MoCA recall question and was off the Montreal Cognitive Assessment Test. It's a common cognitive impairment screening tool, and the MoCA abstract question. I can show examples of those later, or describe them to you later in detail if you're interested. And the last question was, do you use a cane, walker, wheelchair? These are predictors for people's probably level of frailty or their physical ability or debilitation. This is just to show you the road annual safety report. To put in context, the 75 and over category that we're looking for, as you can see here, the overall total percent of drivers who have a collision is 2.3. We have a higher collision rate based on our population. Again, these values from the Ontario Road Safety Report, approximately 60% of our drivers in the study were from Ontario, is higher. Our at-fault collision rate was in fact approximately 1.8%. So, and that's about half the drivers. So we're probably about a 3.6% police reported crash rate, higher than one here. But ours was high volume drivers versus this does not take into account the driving habits of those involved. I think this is the main study finding where I'd like to highlight where we're at. So what did we do? Well, what we did here was we categorized things. We applied the risk stratification tool to person years of driving. So people may have attributed multiple years of driving, but when we break them down, this is how the categories came out. And I think the key thing is that we have, this is the majority of the population here, 75% of our drivers were within this low risk category. This rate, at 1.8% collision rate, we feel is similar probably to older drivers comparing these sort of data. And then we had 3 other categories of driver risk based on the stratification of this tool. These are just the point system that we use. The highest risk category group here represents 3% of the person years of driving within the study. The risk here is 5.26. So that's a relative risk fivefold compared to the regular drivers. Put it in a context, that in context, they're about 9.4% was the collision rate for drivers in that category. So is this meaningful? And this is where we're coming off. Of course, this is a derived tool. We're going to talk about the limitations. But what we're really saying here is this is pretty significant compared to other potential groups. To put it in context, I just refer to, I think you are a very vested crowd and have just listened to the driving talk about driving under the influence, but probably has the best data about what does relative risk mean. And I think that this is useful because it's from studies even going back to the 1960s and even as relevant recent as 2002, showing that really when you hit the impaired risk at about 0.08 level, your relative risk of collision compared to the lowest, the people who are not impaired, is a 3.2 relative risk. And I'm saying within our Candrive study, we're finding this older group has a 5.26 or 5.3 relative risk. So higher relative risk, just put in context that these people probably are at more serious risk for at-fault collision. The older driver risk stratification tool. Well, what do you do with it? So you got this tool and you got it back. So we fed it back to stakeholders. And we went back and asked them some questions on this tool, where it's at. Happy to take your feedback or questions if we have time. What are the appropriateness of the categories? Are these categories meaningful to clinicians, healthcare administrators, road safety administrators? How should the tool be used? In what context? Usefulness? Should it be used at all? Is this helpful? If it's not helpful, well, I couldn't use it. Who should the tool be administered to? What is the population, medical condition? This was a volunteer population who signed up for a study of healthy older adults. We do know, and the Candrive data shows, that as we followed them prospectively over 7 years, their health deteriorated. So we know that the person 75 versus 82, when you take a big enough sample, we know their health will deteriorate, and this is what happened. And our data is showing that, in fact, the people who dropped out of the study tended to be less healthy, therefore losing. So the feedback came back in different points. How do we interpret each category? Is low, medium, high interpreted? We have some feedback on that. I'm happy to talk about that, but essentially, I think there's clear indication on the low group, how to handle those. If you've raised questions with driving safety, you would say that really, well, you're at the same risk as other older drivers, but not necessarily better or worse, same risk. And then for people in the higher category, they may be at risk and you want to know why. And you need, as a clinician, if this is used by a clinician, you would want to make sure that you're not being unfair in that application. For instance, if they've used a cane their whole life because they had a knee injury, the tool wouldn't necessarily be useful if you have a heavy waiting for use of a walking aid. But if they have newly acquired walking aid, that would be kind of a time when you might want to consider that as a risk factor for them. The limitations. The limitations of the Candrive risk stratification tool is that it's a derived tool. So, yep, we started a study with 1,480 variables. If we'd actually come down to it, we did not administer this as a singular tool with 4 items. We did not have it done on a prospective basis. So the significant limitation of it is that it is a derived tool. Does it mean it's invalid? It doesn't mean it's invalid, but it means that based on the population, these people are higher risk, but we took it from a constellation of variables. The study population was primarily healthy older drivers versus older drivers identified in a clinic setting with concerns for driving ability. So what does that mean? Well, as a physician, who are you going to adjust? Who are you going to use this tool with? We use this and derive this on everyone who is an older driver in our study when they're applying this tool and results. In a clinic setting, I don't see this tool being used on the 71-year-old CEO of a company who injured his ankle on a marathon on the weekend and saying, hey, would you like to do this driving risk stratification tool? That's not what this is geared for. We actually found out one of the last variables we actually took out of the equation was, does your doctor have concerns about your driving? It didn't include that, but that's probably where this tool is to be used, is to help start a conversation. How will this tool be used? In a positive way, hopefully. That's where when we're going for our publications, these are things we're trying to indicate that this is used as a conversation starter. And we have some preliminary pilot data from some other projects I'm not reporting on today that suggests that that's how it can be used as something to start a conversation, to open up the box of, hey, let's talk about driving something objective. And it's kind of more of where we're seeing things coming from. So with regards to the Candrive tool, we see it as kind of heading in that direction, and hopefully it will be a benefit. In my next talk, I'm going to talk about some preliminary validation, because the real question you have is, okay, so you did the study, you used some statistical wizardry and came up with some results. The results themselves should show some, show some concern, because you can identify as higher risk group who are for at-fault motor vehicle collisions, so an objective outcome with higher risk. But the truth of it is, at the end of the day, is does this carry over to other populations? Can we use this? The things that we've said today are, one, we have compared the Candrive population to older Canadian drivers through the Canadian Community Health Sample. We have, identified this as a primary outcome. And as that fault collision, which our group and talking to our stakeholders, people recognize as something to avoid versus car fender benders. And ultimately, this can help and be a useful tool if put and used in the right context or hands. So in conclusion, the Candrive risk stratification tool may aid primary healthcare providers in initiating a conversation about driving and to guide further evaluation of fitness to drive in older adults with medical conditions that may impact their driving performance. And again, I think it's interesting in the older driver population, as you saw even from the talks today, this isn't necessarily about driving under the influence. This isn't about behaviors. In fact, behaviors, if anything, tend to be more, I guess, publicly better than younger behaviors, or tend to be a bit more aggressive. This is about health. And this is about trying to identify those who are at risk. And most of our older drivers, when we talk to them, don't want to be at risk. Ultimately, future validation and clinic setting will be necessary. And I can talk about that next session. I'd like to thank all the Candrive contributors and collaborators that were present today. Thank you.
Thank you. So do we have any questions for Dr. Marshall regarding the development of the stratification tool? So I had a quick question about the MOCA, if you don't mind me asking. So you took a couple of items out of the MOCA and that became part of the stratification tool, but not the entire MOCA. Is it just statistically it didn't contribute overall, or?
Statistically, we had numerous things contribute statistically. And the MOCA overall does have a sort of trend. We broke it down by item because the main thing is with this tool is we wanted a tool. Okay, remember, this is done early 2010s. I don't know what we call them anymore. But that was kind of when this was developed and conceptualized. And not everyone had computers here, there, and everywhere. We wanted something quick and simple that could be used at a clinician level. That didn't take the MOCA, for instance, minimally will take you 7 to 10 minutes to apply. We wanted something to be applied, very shortly to kind of in the under 5-minute mark. And so, yeah, many variables do contribute statistically to predicting this. Those two items came out as particular when we broke it down. The whole score could, but that would mean you'd have to apply the whole MOCA and use that. And it wasn't as powerful as taking those specific elements out of it, because certain elements within the MOCA, because it covers all cognitive domains, aren't necessarily relevant to driving.
Dr. Marshall, from your data, can you determine which medical conditions are most likely to pose a risk of collision for older drivers? Being an older driver, I'd like to know what I should be looking out for.
So we do have a lot of data on that as to which specific driver, and I think that's a really good question. And I think what you'll actually come down in the MOCA is really about, and in my area especially, is about function, and really it's actually and driving is a functional behavior. So do we know statistically, and from great meta-analyses and systematic reviews, I think from Jude Charlton and her group, from Australia, and Jamie Dow has just recently redone the recreation of kind of the medical conditions and driving reports. And we know that there's statistical increases on the rates of different conditions that contribute to driving. The challenge is when I do when we did a paper on the medical conditions of driving, it was very much like you're driving on the influence paper today. Most people over age 70, if you take people over age 70, the majority of people actually have more than one medical condition. It's actually often three. I'll give you an example. If someone's had a stroke, they often have coronary artery disease, they often have vascular disease, and they often have other conditions like diabetes, which are all contributing. So specifically, we can look at different conditions, but to identify the condition, just like identifying age and contributing that to not being able to drive, probably isn't where to go. It's a risk factor. It's probably something to consider when you have that conversation with the patient saying, listen, these are contributing to your declining function. It's how I'd see that being introduced. But going specifically by conditions, not going to work as much, because diabetes, for instance, is an example, is on a spectrum of people who control a diet to people who are insulin dependent, who can actually have hypoglycemic reactions, who are at more risk of driving. So and same with stroke. You can have a mild stroke where you completely recover, or you can have a stroke where you're actually in a vegetative state for the rest of your life. Diagnosis doesn't necessarily hand out, but it does probably lends to problems. I think a functional assessment is probably the approach to go, which is what we're advocating.
Okay, so why don't we leave it there, and we'll go on to the second presentation, which is the validation of the tool.
Great. Okay, well, thank you again for. Now, I'll just give you a full disclosure. So this is preliminary validation of the Candrive older driver risk stratification tool. And my compliments to Michelle Bedard, Sean Capel, Jude Charlton. Michelle's from Lakehead, and Sean and Jude are from Monash University in Australia. And they're part of the Candrive Oz Candrive research group. And we've been working together on the preliminary validation of the Candrive older driver risk stratification tool. As I said, prove to me it works. So we've shown it, we derived it, we used evidence to create this tool. And we're now going to use this tool, and we're going to look at kind of what can we do. So while the Candrive risk stratification tool has been developed using a rigorous process, further validation of the tool is essential to ensure its applicability in the clinical setting. Existing data can be used to examine associations between the risk stratification tool classifications and driving outcomes. So that's what we're going to give you feedback on. So at the end of the day, I can tell you the one thing about working with our Candrive group, I'm probably on the more, liberal end of wanting to use it because I'm a clinician in the front line. But I can tell you that a lot of the Oz Candrive researchers are very hesitant about using this for fear of overcalling. You don't want to overcall for older drivers. Because at the end of the day, we want older drivers on the road. For the many reasons that you're here at the conference today, it allows for independence. A lot of people, it allows for mobility. And we know that when driver licenses are rescinded or taken away or given up voluntarily, their lifestyle changes and has impacts for older drivers. So our aim was to really examine the validity of the Candrive risk stratification tool. So you've developed this great tool. I just showed it to you there. I think it's great, but I'm certainly biased. But at the end of the day, does it work? And the truth is, it may not. And that's the beauty of research, isn't it? And the failure of research is sometimes it doesn't. It can make all the sense in the world. I can show you that, many different things and play with statistics. So we want to look at what can we do to validate this? Well, we have an opportunity. We have self-reported at-fault crashes from a separate sample of drivers is one way of looking at it. And we can do this through police-recorded traffic violations collected on the Candrive sample. All right. So here's our methodology for the preliminary validation. So the Oz Candrive cohort. So I showed you earlier, we have the Candrive cohort on which the tool is derived. The Oz Candrive cohort, the tool is not derived on the population. So that's the Australians and the New Zealanders. Active Australian drivers. Now they are different. The only major difference is they're age 75 plus and older. And the older major difference is that Australia and New Zealand have much better weather than we have. All participants completed the same annual assessments as Candrive participants. Most participants contributed several years of observation, some going beyond 7. For each participant, the risk stratification tool was determined according to the results of the 4 risk stratification tool components. So we categorized them. So we took the tools, how they did, and we categorized them. And now we're going to look at self-reported crashes. So the primary outcome measure was self-reported at-fault crashes per person years. If you want to know why we're using that versus police-reported crashes, because the Australians, just like road safety is going in this direction, didn't do police reported crashes. In fact, in the end, almost all of them are insurance reported or self-reported collisions. They show up and we don't have a police record of the crash in Australia. So that was what we were hamstrung by. So we used self-reported collisions. Because of the limited number of crashes in the two highest categories, risk categories, they were combined to one category. So instead of going to 4 of low, medium, and high risk, we go to low, medium, and high risk group. So the top 2 were combined into high risk. We then calculated the incident rate ratio of an at-fault crash compared to the lower risk category. Okay, and the at-risk crash was the at-fault crash was determined by the driver. We have some background data to show that they're pretty accurate in that self-reporting, and it matches the Candrive sample and self-reporting in relation to the police reported crash. Methodology, so for traffic violations. So another approach. Okay, so we're going to use the Candrive data. We've got police reported outcomes for their collisions, but we also have police reported outcomes for all the traffic violations. Outcome measures were police reported traffic violations, of course, they're the ones who are going to report it, obtained from relevant Ministry of Transportation. Because not all traffic violations may indicate poor fitness to drive, we divided the violations a priori into speeding and cognitive violations. Speeding, self-explanatory. We verified all instances were above the speed limit and one instance was over 45 kilometers per hour higher, so pretty fast. I think our rationale behind the speeding was that I'm going to guess that any of you drove to Sudbury today, some of you might have exceeded the speed limit coming to Sudbury. It can actually be a sign of confidence and better driving. It's, you don't necessarily drive, at least in the 400 when I was coming up yesterday, not everyone's going 100. I can tell you that some people are going over 110 in places, 100 in other places. And in the cognitive road sign rule violation, it included unsafe road sign rule violation, unsafe driving, or traffic light violations that may be more related to cognition. This is our hypothesis. So we've given the low number of violations overall. We divide into low risk and high risk. So the low risk group, as you saw before, from the Candrive tool, was 75% of drivers fell in the low risk category, and the other 25% would be in the higher risk category. We used a generalized model to account for nested nature of the data. That means that we had 5 years of data. One person would contribute 5 person years to that data. Every single year we did an annual assessment, so we need to control for that. And we adjusted for age, kilometers driven, and gender. So the results, and now results of the self-reported crashes. So I just told you about the methodology. Now we're going to go to results about result 1. So this was the Australian data. 257 AusCan drivers. So those are the ones from Melbourne, Australia. 71% were male. Mean age was around 80. And again, they started off at age 75 as the lowest entry. 927 person years of driving. So these drivers, of the 257 drivers, they obviously contributed multiple years to driving data. And they reported 248 crashes. 140 were at fault crashes. Now, we did go through, and on those 140 crashes, these were meaningful crashes. We took out fender benders and these sorts of things and had an algorithm to decide that they were meaningful. There was significant damage to the car done on the highway or road. They weren't hitting the garage, taking your driver's side rear view, driver's side mirror off, backing out of the garage. And this is how it fell out. And I think that the key thing here that we want to highlight here is, is that in a higher risk category, so this would be the drivers of 100 plus points, you can see that these drivers had a risk ratio of probably 1.7. So not to the same level, but in that range, it's significantly higher than the lower risk group. So probably approaching 2 times. Now, we did see the very high risk group was between 2 to 5 times. When we looked at the Candrive data, this was collapsing the 2 groups because you can see the at-fault collisions were lower in this 100 plus category group. But it does lend that statistically, this is trending that these drivers are at increased risk for at-fault collisions. In the traffic violation results, 928 Candrive drivers, 60% male. The average age of 76 is which we knew. And then again, we broke them in 2 categories, the 75% in the low risk category and the other 3 categories combined to 25%. The average kilometers driven, these are relatively high volume drivers, was 10,000 kilometers per year. 276 violations, 163 were speeding violations, 87 were cognitive violations, and 26 others were things like not having your documents available in your car, like insurance, weren't wearing your seatbelt, and we did have a number of DUI ones, which we didn't know, so we split those. The results for speeding violations. So this is the data that we have on speeding violations, and you'll see highlighted that the exponential B, so the relative risk is 0.965, which is 1, which is not significant. So you look at the confidence intervals from 0.6 to 1.4, crossing 1, it's not significant. So for speeding, it does not seem to be, when you look at the high risk group and the low risk group, there's no real difference in speeding violations for those two groups, which our hypothesis was that could happen. It could happen that people, in fact, it could happen the other way, that people in the lower risk group were more likely to speed, but there was actually no difference between the two groups. In the cognitive violations group, we did see a difference. And here, the main difference is, as you can see highlighted in yellow, the overall risk was 1.6, confidence interval 1.01 or 1.02 to 2.57. And you can see within regards to that, that suggests that these people were more likely in the group that has the cognitive impairment or our higher risk group, they're more likely to have had a cognitive violation, so a traffic violation, suggesting that they were more at risk. So these are the people who got the failing to yield type of ticket or a traffic or a stoplight violation. So discussion. A higher risk Candrive stratification tool was associated with self-reported at-fault crashes in the Candrive sample. So again, at least the population is derived differently. We can show it's statistically different. The Candrive cohort was not used to derive the RST, and the association suggests the tool could be used in other settings. Similarly, Candrive participants in high-risk category had higher odds of having a police-reported cognitive violation, as hypothesized, but not higher odds for speeding violations. Both outcome measures represent adverse driving events. So we can each, can certainly say that they're reporting something that's meaningful. Limitations. Well, there's there's inherent bias with self-reports. Although participants may have been reluctant to report the crash or admit at-fault status, however, such tendency would bias results towards the null hypothesis. So if they're more likely to say, no, I wasn't at fault, in fact, that would have gone towards actually negating the effect that we found. And we didn't adjust for distance driven, which is the next step in our preliminary validation, which we're able to do. Limitations for traffic violations. For 22% of the at-fault collisions, there was a violation assigned within 60 days, hence traffic violations, and at-fault crashes used to drive the tool. So it may not be independent events. So they may have crashed, which is what we use to derive the tool. And that crash may be related to the reportable offense that came within 60 days of their collision. So there's a potential for confounding there. That's one weakness. However, the bias does not appear present for speeding violations. So the speeding doesn't seem to be tied to it, but the cognitive violations do. So we are doing more work to clarify the link between a cognitive violation and at-fault crashes to further validate that. Conclusion, the association of the Candrive risk stratification tool classification and two separate driving outcomes in the expected direction supporting our further research. Validation of the tool in a clinical setting will provide the evidence required to justify its implementation. And currently we're working on the implementation. We're looking at the combined implementation-based study and validation study combined, and we're in the phase now of piloting that work, working with our partners, with the challenge of recruiting people to participate in the study, because there's always the chance that this could impact your driving status if you're participating in the study. So we have multiple researchers and research centers involved, and again, I'd like to thank them and take any questions if we have time or interest. Thank you.
Thank you very much for that. And a quick question, though it might be outside the scope of the research, but we have a lot of discussions during this conference on speeding and violations, but particularly talking about an age population. Is there any look at driving too slow when the speed of traffic around you, though the speed limit may be 100, the average speed is 110, 115, and then you have someone who's driving 80? Is there any look at that and the consequences of that?
very good question, and it's certainly come up in our conversations in the group because there's many different things that we can look at kind of this in this validation, and we're looking at different approaches. I just didn't show you these. Now I'm going to show you. I'm going to be honest in our validation. These are the two we started with because we thought they're the winners. And in that one, for instance, going too slow. We can look at that data. Our challenge in looking at that data is speeding is pretty easy to capture, and we can actually look at kind of not just the speeding violation. We can actually capture if they actually speed all the time. So, for instance, we know the posted road sign speed, and we know the speed they're traveling, like literally to the second for all that. And we've done some big data analysis for this. The challenge with that one is we don't know. Okay, maybe for our more rural people, we know they get to travel the speed limits, but we need to look at, for instance, for our Toronto drivers, we wouldn't know if they are stuck in a traffic jam or bad road conditions. We could figure out the road conditions maybe because we have that data, like if it was icy or something like this, like, the qualifiers. So the challenge is when we talk about it, we wouldn't know if they're, I don't know if they're stuck behind someone who's going slow within the driving. But we could look at that. We do have the ability to look at their overall driving pattern. Do they tend to drive slower on average? And we are trying to look at that. That would take a big data analysis. And that usually when we run that, takes a day or two on the computers to run, but we are interested in looking at that as a predictor. And that's actually ties to another project we did, which is the driving signature project, which means we can actually tell by just the way you drive the car who the driver is. So at one point we were worrying about radio frequency identification because it was your spouse or you driving, we had PFOB. But we actually, for people who had missing data in one part of our study, we actually went through and said, well, guess what? I can tell you're driving this, not your daughter, because your daughter drives way more aggressively than you do. And so you can actually tell by how you drive and speed, because you're doing the same stuff over and over again. It comes like a pattern, just like how you walk. You can tell someone's walk from a distance. We can tell their drive from a distance. We're looking at that. That's a great question. We don't know.
Any other questions?
Follow-up question related to Brian. How do we adjust for assisted driver assistance technologies today? If a person has a bit of mobility impairment, he can now purchase a vehicle that has blind spot detection, turning cameras, rear backing cameras. That'll eliminate that problem.
That's, so the question about the assistive driving technologies, we have the information on who is using it on the assistive driving technologies. How to accommodate for that is going to be harder. We can look at vehicles and look at trends. But we also don't know if they use it. So for instance, we know if their vehicle has it. We don't know if they turn it off, ignore it. And in fact, in some states, it's suggested that it becomes too much for them, right? There's too much assistive technology, because it becomes a bit overwhelming, all the different gadgets. And it's kind of like your old-fashioned VCR or now it's your Roku at home. How do you use all these different buttons on your TV remote control? And same thing with the car. Do you use all these features to their maximum, or they're enforced upon you? So you don't have that, but I think we have some ability to look at that. But how? And the key thing is, so I think the bigger question you have for it is, does this decrease their safety risk? Because that's the real thing you want at the end of the day is are they safer because of it? Because if they're a safer driver, are people who, for instance, who use this technology less likely to involve in a crash? That's what I'd want. At the end of the day, it's all headed for, right? Vehicle and safe. So, but yeah, we don't know, and it doesn't make up for it. We know that conditional licensing, I've done some research in that area, like conditional licensing does make people safer. We don't say why. We know it does. No, and I love that. It makes sense because the vehicles are, not designed for the elderly. They're definitely not designed for that. So I think that would make sense on different technologies. One of the projects within the Candrive group is looking at the technology and attitudes of the older drivers with the technology. So Brenda Berkeley and her group, master, she's not going to therapist, focus a lot on.
Okay, so my last duty for you, Dr. Marshall, is to give you these donation cards. They are donations in your name to the Cars Youth Professional Group. You're welcome. Okay, so our last speaker is, let's see here. So our last speaker for this session is Dr. Evelyn Vingilis. Dr. Vingilis is Director of the Population and Community Health Unit and Professor with the Departments of Family Medicine and Epidemiology and Biostatistics in the Schulich School of Medicine and Dentistry, Western University, London, Ontario. She's a developmental and clinical child psychologist. Her two main research programs are injury prevention and control and mental health and substance use, with a particular focus on at-risk youth. In 2010, she received the Widmarker Award from the International Council on Alcohol, Drugs, and Traffic Safety for outstanding, sustained, and meritorious contributions. In 2018, she received the Lifetime Achievement Award from the Canadian Association of Road Safety Professionals. Dr. Vingilis.
Christine. The first thing I'd like to do is to acknowledge all of my co-investigators, and I have three sitting around the table, so thank you for working with me on this project. And what I'll be talking about is the impact of COVID-19 on alcohol in driving and cannabis use in driving. And this is based on a population-based survey of Ontario drivers that we developed. Now, the first thing I want to say is I think all of us know that March 20th changed our lives quite immensely. The World Health Organization declared the coronavirus disease as a pandemic. And as a consequence, countries around the world engaged in various kinds of public health measures, including massive lockdowns. Now, these massive lockdowns also led to decreases in GDP of countries, and historical research has found that if you have a downturn in the economy, you tend to have fewer people on the roads because they've lost their jobs or they don't have as much disposable income for social types of driving, and you tend to see a decrease in the number of collisions and fatalities. If you take a look at what happened during the pandemic, certainly in 2020, we do see, as from this particular International Transport Forum annual report, that we did see across different countries that they investigated decreases in the total travel distance driven by their constituents, but you can also see that there's variation amongst the degree to which drivers have decreased their driving. We also noticed that during this period, traffic fatalities in different countries generally, this is also from the same study, and as you can see, the vast majority of countries did see a decrease in the number of traffic fatalities, but 3 countries that they investigated showed an increase. Ireland, Switzerland, and the United States had the largest increase. Now, if we look more locally for 2020 Transport Canada data, we see that we did have a decrease in the number of motor vehicle fatalities. It was a decrease from 2019 of 1%. But if you examine those fatalities per billion vehicle kilometers traveled, you see that we have increased in 2020 to 4.7 compared to 4.4 in 2019. So although the numbers decreased, if you examine it by vehicle kilometers traveled, we also had an increase. We did have a 12% decrease in serious injuries, but interestingly, we had a 32% increase in the number of occupants that were killed or seriously injured that weren't wearing seatbelts in 2020 compared to 2019, a pattern that was similar to what they found in the US. And I guess I, as a psychologist, wonder that if you put controls on individuals in one area, do they react and rebel and say, I'm not going to follow the rules in other areas, I'm not going to wear seatbelt, I'm not sure, or maybe it's different populations that are driving. but I do wonder. One of the issues that has been found in our country and other countries, if you look at actual alcohol and cannabis sales, is there has been some increase in various regions across the world showing that alcohol and cannabis have had higher sales during the COVID period compared to pre-COVID times. However, the question is that affecting driving? And we've got limited information about whether individuals are drinking and driving more or less, or using drugs more or less since the pandemic. One study done by Van Laar did find that 22.1% said they were driving less during the pandemic. This was a survey study, while 2.4%, a small percentage, said they were reporting more drinking driving. In the US, the same question yielded a higher percent that reported that they were drinking driving, almost 3 times as high as we had. When it comes to drug use, they found that 20.6% said that they were doing less during the pandemic in Canada, while 2.2% said they were doing more. And similarly, the percentages are a bit higher in the American population. So we decided, a group of us, that maybe we should engage in doing our own survey to find out what was happening in Ontario. So we developed this population-based survey that was investigating attitudes, opinions, and behaviors on a range of transportation groups. But the purpose of this presentation is we are focusing on the 2 questions of cannabis and alcohol and their correlates during COVID-19. And we specifically examined sociodemographic, psychological factors in substance use in our analysis. Now, the survey was developed using an expert panel method, and this is an online panel survey. Now, online panel surveys are based on a system whereby you have got large polling companies, market research firms that have a large poll form across for the study. And so we used panels. Now, the panel was conducted by the Survey Research Center at the University of Waterloo during the latter months of 2021, and the sampling was done by quotas, by age. So you can see the different age categories they sampled, and done by gender, and also by the type of community. So the sample that we obtained was almost 1,600 participants. The response rate was 17.3, which is a little bit of a misnomer, because that's of all of the potential individuals that could have responded to it. That's what the sample rate was. So that with the quotas, it would have actually been higher. And the sample weights were applied to approximate non-institutionalized Ontario adult population. Now, our outcome variables were 4 of the questions that we had, and we were interested for these particular analysis in examining, has there been an increase in risky driving behaviors? So our outcome variables are, apart from the collision data, are looking at the question of whether individuals said, yes, I've engaged in more of these, compared to those who said, I don't do it at all, I've engaged in less, or I haven't changed in my behavior. So our 4 outcome variables are driving after 2 or more drinks of alcohol in the past hour, driving within 2 hours of using cannabis, a third question that looked at the combination, driving after 2 or more drinks of alcohol and using cannabis. And then we also had a question of, have you had any collisions since COVID? Our correlates were demographics, age and gender, driving frequency, the region that you lived in. We included the Kessler distress scale as a measure of stress. We have the competitive attitude toward driving scale, which measures an individual's almost sensation seeking and competitive mood in terms of driving and changes in self-reported alcohol and cannabis use. We also had a range of other questions, did do a number of analyses, and a number of other questions that one would hope would show some relationship. Didn't find anything such as, do I feel there are fewer police on the road? Do I feel that there's less traffic on the road? Am I worried? So to present the population frequencies, the quota sampling matched, you can see that we've got frequencies from 16 through to 80 plus. And as I said, it's a population-based quota sampling. The gender, you can see again, it's matched to Ontario population, so we have and also regionally, the quota sample to fit within population sample. Now, examining the results, we first wanted to know, and these also are of individuals that are licensed drivers who have said that they have driven, examples for individuals that have said that they had driven within the last 3 months, last year. So if we ask the question of in the last 3-month period compared to before, have you been driving? You can see that 30% said, well, I'm driving about the same. Almost 50% say that they have been driving less, a lot less or somewhat less. And then you've got about 22% that say that they've actually been driving more or a lot more since the pandemic. Examining the questions that were the outcome questions. So since the start of the pandemic, how often, if at all, have you engaged in the following activities compared to before the pandemic? Of those who responded to the driving after 2 or more drinks in the previous hour, you can see that the majority, the vast majority, do not engage in this behavior. So you've got about 84% not engaging in the behavior. 6% say that they are doing it less. 7% the same, and 3.3% say that they were doing it more. Examining the same question. That's missing as well. Strange. Oh, cannabis, yes. With regarding cannabis, we've got similar patterns, but 85% don't do it at all. 5% said they were doing it less, 6% doing it the same, 3.5% said that they were doing it. And looking at the combination, we've got a little higher percent so they don't do it at all. And it's a very similar breakdown in terms of those that say they've done it less, the same, or more. For the collisions involved in a collision since the pandemic, 93.5% say that they don't do it at all, or they haven't had a collision at all. We have 5% at one collision, and so interestingly, 0.3% have had 4 or more since the Now moving into logistic regressions of the correlates. So first examining the drinking question, you can see that for the logistic regression, age is a significant predictor in which individuals that are younger have higher odds of being involved, of engaging in drinking driving. Competitive driving scale is a significant predictor. Any use of cannabis during the pandemic and were significant without more alcohol use approaching significance. For the cannabis question, we have age, kilometer driven, competitive driving, and use of cannabis as significant predictors of engaging in more frequent cannabis. For the combined, the age does not pan out, kilometers driven, competitive driving scale, and use of cannabis during the pandemic all are significant predictors. And as you can see, the use of cannabis has got a very high odds ratio. Individuals that use cannabis were using cannabis during the pandemic reported 5.79 times higher odds of engaging in driving after drinking cannabis. In terms of collision, the predictors are competitive driving scale, use of alcohol during the pandemic, and approaching significant with use of more alcohol during the pandemic. So to conclude, we noticed that almost half of respondents reported reported driving less in the last 3 months compared to pre-pandemic, but 1/5 reported driving more. The majority did not report driving after alcohol use, cannabis use, or using both. Since the pandemic, about 3% reported engaging in more frequent driving after cannabis use and after both. But that still translates to about 150,000 Ontario drivers driving more frequently after those who reported more frequent driving after alcohol use had higher odds of being younger. And competitive attitudes towards driving, as you can see, was a significant predictor for all 4 of the outcome measures that we had. A self-reported cannabis use was also a significant predictor of more frequent driving after alcohol use, cannabis use, both and self-reported increased alcohol use through the pandemic only approached significance as a predictor for more frequent driving after alcohol use. So examining these, clearly we would need to have interventions that focus on certain age groups. We need to think about competitive attitudes towards driving and also focus on individuals that are engaged in cannabis. And our limitations are, it's a cross-sectional survey, obviously mortality trends can't be determined. We have the same issue in terms of self-report of social desirability, where you could have under-reporting, over-reporting. Some of our cell sizes are small, and although the sampling weights by age, gender, and region were computed to approximate non-institutionalized Ontario adult population, did select for individuals that had driver's license and had driven within the past year. So, finally, I'd like to acknowledge funding by the Ministry of Transport. I would like to thank the Survey Research Centre of Waterloo for their administration of our survey, and to thank colleagues from the
Okay, so we're at the end of the session. Were there any questions for Dr. Vingilis? I have a comment, but I preface that I was a co-author on this project. But I'm really excited by the fact that we have self-report data, because I'm a little bit concerned that when we start to look at charges and convictions of some of these charges, I'm not sure that they're going to be entirely reliable for that pandemic period. With the courts being sort of shut down, I'm wondering if those charges are going through the system the way that they should be. And so are they a true reflection, or will they be a true reflection of what happened during the pandemic? And so I think it makes the self-report data that much more valuable in a time when it was very, very difficult to do research.
For the data point with regards to cannabis use, you guys selected 2 hours. I was just curious as to how you, why you chose 2 hours instead of the 4 hours. I think because Health Canada mentions 4 hours and last use. That's the recommendation.
There are variations in what various surveys do. Some have used 2 hours, some have used 3, some have used 4. We wanted to follow something similar that is used by CAMH in their survey so that we could have some comparative data for what they had done. That was the purpose. We wanted to have some that could be a trend, but it could highlight.
So yeah, I see a lot of patients and they're always telling me things that I don't know about cannabis, but did they give you any attitudinal, do you have any information on the attitude? Because you've actually, it's great that you can actually contact these people directly, they answer questions pretty honestly. Did they give you attitudes about like cannabis use in particular? I think they, and just their beliefs and kind of how they're using it and going out within 2 hours of using it, because it's very confusing to me.
For this particular study, no, we don't have those questions. We had some other ones regarding their sense of whether they had been vaccinated, their fear of COVID, etc. We were limited to have a survey that was 10 minutes. So we tried to pack as much as we could in it. Apart from the competitive driving attitude that we included as an interesting measure, we don't have any interesting to have.
If you want to come to this to the next session after lunch, I do have a presentation on risk perceptions. So a little plug for me. Okay. Okay. So thanks everyone for coming. It's been a great session and we will see you after lunch.